The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. We're going to do a quick little podcast on mechanical ventilation. Haven't done a podcast on mechanical ventilation in quite some time. I am actually going to redo the mechanical ventilation podcasts, part 1, part 2, part 3 in the coming month, maybe 6 weeks, just because I think that there's a lot of data that has changed, and overall my understanding to mechanical ventilation has definitely changed over the last 3 or 4 years. I think anytime you don't grow, and I think it's really interesting when I listen to some really old podcasts that I've put out. It's amazing some of the things that I hear myself say. And I think that just means that I've learned a lot, that I've continued to grow, and I need to go back and kind of change those and add to them and redo those. So I've had a few emails on questions, and it's just kind of comical, some of the things, little itty bitty things that I say that maybe my understanding was not to the level that it is now. One of the big focuses that I think we always need to look at in medicine is doing things based on the standard of care. And we know that in critical care medicine, the standard of care for any intubated patient is placing the patient on the mechanical ventilator. That is absolutely the standard of care, and I think that's a standard of care for all HIMSS companies, I would say. There may be some that haven't gotten to that point, but I can tell you that is a kind of a CQI measured thing. And one of the things that we always look at is, do crews, whether this is a ground crew or a flight crew, can they manage these patients that are very highly sick? Maybe they have a refractory hypoxia, maybe they have an abnormal presentation, and can they manage these patients on the ventilator and kind of troubleshoot and utilize some advanced thought processes? I think we're only as good as the types of patients that we fly or we transport on the ground. And if you're flying at a HIMSS agency that uses some advanced modes like APRV or maybe high frequency ventilation, things like that, you're probably really good at those subsets of patients, and those patients are very sick. But for the standard HIMSS crew or the standard ground crew that transports critical care, those patients are very rare, right? You're probably going to get a few of those a year that are very highly sick. And so one of the things that I'm always looking at when I'm looking at charts or I'm teaching is, did a crew or a transporting agency, did they have to take the patient off the ventilator? And I think it's important to kind of say this in the right way. If you have to take the patient off the ventilator to diagnose an issue, if you can go through your dope pneumonic, then go through your dope pneumonic. But I think it's important that we kind of illustrate a few things that may help you in those situations where, man, this patient is highly sick. You just can't ventilate them. You can't oxygenate them, and kind of remember the differences between the two. So let's kind of hypothetically think about a patient. You have a 65-year-old female patient that is in a small hospital. She was brought in by EMS, and she's got a long history of CHF. She is intubated on your arrival, and they're bagging her with a bag valve mask. The respiratory therapist is bagging at a very fast rate, and the patient has had very little for sedation and pain management. You move the patient over to your transport ventilator, you give her the appropriate pain management and sedation, and you immediately start having difficulties with maintaining an SpO2 greater than 93%. And so what are some things that we need to kind of do? What are some things we think about? Well, most companies are going to have you start on a volume mode of ventilation. And so in this podcast, I'm going to kind of focus on the LTV 1200 and the Revell ventilator. I think those are the two most popular ventilators out there. Obviously, if you're utilizing a Hamilton T1 or an impact vent or a cross vent, things like that, then, my apologies, but I think a lot of places have moved away from those other vents. And I know the Hamilton T1 is gaining ground. But when we think about a patient that's hypoxic, refractory hypoxic, you've just moved them off of a BVM onto the ventilator. There's a few things to remember. The first thing is did that BVM have a PEEP valve? And we know that PEEP valves are the standard now, right? We've talked about this on other podcasts, that if you're utilizing a BVM, you should have a PEEP valve on. And we know that 10 a PEEP is the old 5 a PEEP, right? 10 a PEEP is going to be a good augmentation to maintain recruitment. I just had an email on PEEP versus inspiratory, kind of the inspiratory phase, and which one actually does the recruiting. I think it's important to remember that when you deliver a breath, whether that's via a BVM or a ventilator, most of the recruitment happens during that inspiratory phase, right? That ventilation of that tidal volume. PEEP then maintains that recruitment during exhalation. If you have dependent areas in your lung fields that have not been ventilated appropriately, you have some atelectasis going on, yes, eventually that PEEP is going to recruit those dependent areas, and you're going to have some better recruitment. But I should say that your primary recruitment kind of measure is going to be your inspiratory phase of delivering that ventilation based on that tidal volume. So we have to maintain that PEEP. And if you're going to have a patient that's on 10 a PEEP, they're bagging them. Remember, we need to clamp that ET tube. So you need to kind of have this in correlation with your partner, with the respiratory therapist. And when they give that breath, that peak of inspiration, you're going to clamp the ET tube, you're going to have your ventilator on, and you're going to move the circuit off. Or I should say, you're going to move the BVM off, and you're going to add the circuit onto the ET tube, and then you'll unclamp that tube. You're going to maintain the same PEEP as the respiratory therapist or whoever's using the BVM had prior. So that's going to maintain that level of recruitment. That's very, very important. We also have to understand how our patients are being ventilated and what the difference is with a BVM and a ventilator. And so with this patient, right, you have real difficulty with maintaining an SpO2. So you're trying all these different things. The two things that we utilize to improve oxygenation is, number one, FiO2. So you turn your FiO2 up to 100%. And number two is your PEEP. Those are your two primary kind of ways to look at improving oxygenation. And so you've done both, right? Your FiO2 is 100%. Your PEEP is at 10. Depending on your protocol, depending on where you work, you may be able to go higher than 10, but a lot of places still look at PEEP very conservatively, and they want you to have some type of online medical direction going higher than 10, maybe 15, again, depending on the company you work for. So let's just say you go up, you get permission, you go up to 15 a PEEP, and you're still having difficulties. Your vent is alarming, you have high pressure alarms, your PIPs are, we'll say 50, 55. You've re-evaluated your dope mnemonic. You've identified that you have no secretions. You've identified you have no kinks in your ET tube. Your vent circuit is clear, and you're still having difficulty. So as you're going through the dope mnemonic, you take them off the ventilator and you bag them again, right? You're checking lung sounds. We're still in the hospital. We haven't even moved the patient to the ambulance or the helicopter. And you note that as you start using your BVM again, you have a PEEP valve on. You've maintained that recruitment when you've switched over, that your SpO2s come up. And you're kind of scratching your head like, why do I have SpO2s greater now with a BVM than I had with the ventilator? And so You know what your company stance is, so you try to move them back onto the ventilator, again, maintaining that recruitment. And again, you have a fall in SpO2. Your event is alarming. You're attempting to check plateau pressures. But you really have an inability to do that because your vent keeps alarming. So what do we do in that sense? If your vent is alarming high pressure alarms, you need to turn your high pressure alarm up in that circumstance, right? If you have an airway that's constricted, or you have something that's causing that high pressure alarm, and that's been consistent through the patient's kind of tenure in the hospital, that's nothing that alarm is not telling you anything you don't know. And sometimes, especially when we're in a hospital, guys, everybody's looking at you. All the eyes are on you. And so do whatever you can to silence your ventilators, silence your IV pumps, things like that. You know that you have a high pressure alarm issue. You know you have maybe some constriction. You have something going on. So raise that alarm up so it's not constantly alarming, right? Diagnose that, or it may be consistent. That patient may have a high pressure alarm throughout the whole process of your patient care. So what do we do in that situation? Why is the patient getting better on the BVM rather than the ventilator? Here's the thing. If we think about how a BVM works, and here's kind of the core tip. Utilize your BVM in that sense, like you just did, and think about what you just did and translate that back to your BVM. All right, so what does that mean? Well, when we deliver a breath with a BVM based on the newest science, and obviously this is going to be based on how much help you have, but we know we want to utilize a 2-person technique, maybe a 3-person technique if at all possible. If you're utilizing a BVM for a non-intubated patient, you would want 3 people if you could have that ability. But if this patient's intubated, a 2-person technique is going to be appropriate. Just making sure you have your ET tube is protected, making sure you're getting full squeeze of that BVM. And so you're protecting that airway. One person is squeezing that bag, and we squeeze that bag, or we should be squeezing that bag with 2 hands. The BVM in a fully compressed state like that can deliver 1,000 mils of volume. So if we use 2 hands and we squeeze that bag all the way down and compress that all the way down, we have 1,000 mils of volume that we're potentially delivering to our patient. And we're also taught to deliver that breath slowly, right? We don't want to slam that breath in. We know that anytime we raise the pressure greater than 20 centimeters of water, we have a high potential to open that gastric sphincter, and then you have a potential for gastric contents to come up. This patient's intubated, obviously, and so if that cuff is secured, if that cuff is inflated to the proper amount of volume, you shouldn't have any issue, but we also know that micro leakage happens around that cuff. So again, it goes back to squeezing that BVM very, very slowly. So what did we just learn? We can translate that very easily back to the ventilator, and I know these patients are really, really tough, and we get tunnel vision, and we get frustrated, and we just start kicking the ventilator, right? We blame it on the ventilator. And some of these patients are highly, highly sick. We have to think about a patient that is in pulmonary edema, or a patient that has ARDS, patients like that. Think about their compliance, their chest wall compliance. They may need a larger breath. Obviously, we teach to use lung protective strategies, and all the studies have showed that lung protective strategies are the way to go. And so we know that starting range is 6 to 8 mils per kilo, and when you start getting into lung protection, we're more in the range of 4 to 6. So when we think about lung protection, or that range, right? Lung protection is 4 to 6, and a standard is 6 to 8. That's why I always teach to start in the middle. And if you ever have taken my ventilator course, you know that I'll draw 4 to 6. I'll write 4 to 6 on the board, and then I'll kind of put a space in between, and I'll put 6 to 8. And I put a big box around the 2 6s. And I say you have 2 6s, start at 6. That doesn't mean that some patients don't need higher volumes, right? And so think about, again, what you just did with the BVM. You gave a higher volume, right? 1,000 mils potentially in that BVM, compressing that all the way down, and you delivered that breath slowly. So can you translate that over to your ventilator? Well, absolutely. Raise your tidal volume up. Go to 7 mils per kilo. Go to 8 mils per kilo. So raise that volume up. And then how can you deliver that breath slower? Well, that goes to our third way of affecting change with our oxygenation, and that's lengthening your inspiratory time. So remember, we have an I time button on both of those ventilators, or really any ventilator should have an I time button, and that affects our ID ratio. We know historically, or I should say predominantly, patients need a longer exhalation time and a shorter inhalation time. That's just normal physiology. But some of these patients that are hypoxic like this, they need a longer inspiratory time, and you're going to have to sacrifice your expiratory time. So if we translate this BVM that we just utilized, right, a simple BLS tool, and it improved the patient's SpO2, we can translate that to the ventilator, we'll raise our tidal volume up, and we can lengthen our inspiratory time. So whether that's lengthening our inspiratory time to 2 seconds or 2.5 seconds, 3 seconds, that may be what's needed for this patient. If you utilize advanced modes, if you're utilizing the Hamilton T1 and you have a mode called airway pressure release ventilation, essentially that's exactly what that mode does. It's basically a hybrid CPAP mode, and it's meant to deliver a breath over, or I should say, it's meant to have an inspiratory time of 4 to 6 seconds, and your expiratory time is going to be around a half second, right? So you're sacrificing the exhalation. Your CO2s are going to climb, right? We live just fine at a higher CO2 range. We're better hypercapnic than hypocapnic. Remember that. So for some of those patients, they're so hypoxic that they need a mode of ventilation like APRV. Well, a lot of these transport agencies, including the one I work for, we don't have that capability. So we either have a Revell or we have an LTV 1200. What else can we do? Well, we start out on a volume mode of ventilation. We can switch them to a pressure mode of ventilation or a pressure delivery. So if you're in an LTV 1200, then you simply switch to pressure control ventilation. Your underlying mode will say stays at SIMV. So your SIMV pressure now. Remember, pressure is going to be now based on a compliance. It gives you a kind of a better optimization of delivery, and it has what's called a decelerating flow pattern, which will optimize your oxygenation as well. And it's very gentle for that lung. And so then we can utilize another trick, another thing. Anytime that you have a patient that has a high peak inspiratory pressure, and you're limited on the volume, because remember, your PIP is relative to a lot of things. It's relative to the constriction, the compliance of the airway. It's relative to how quickly you're delivering that breath. It's relative to any secretions, right? You want to make sure that they're not auto-triggering the vent or coughing, anything like that. But it's also relative to the amount of volume you're putting down that small airway. So anytime that you have a patient like this that you're needing to give maybe a higher volume because their compliance is poor, then going to pressure control ventilation is going to be a great thing. But we still have to always think about other ways. And so that's where I get asked this question, and this is something that you may or may not realize that you have on your ventilator. And so the LTV 1200 or the Revell, both of them, if you actually go to your top button that says select, and you hold that button down, and this is the same button you would hold down to go into the vent config or alarm config kind of menus in the back of the ventilator, you have something called rise time. And so the question I get asked often is, what's the difference between rise time and I time. Aren't they the same things? And they're absolutely two completely different things. And I like to use the analogy, right? You're taking your family on vacation. You got your two kids in the back seat. You're driving down to Orlando to Disney World. And so we can utilize I time and we can utilize rise time as a great kind of analogy utilizing that family vacation. When we think about rise time is the amount of time it takes to get there. Okay? So rise time, it takes 12 hours to get to Disney World from where I live. So rise time is the amount of time it takes to get there. And I time is the amount of time we stay there. All right, I'll say that again. Rise time is the amount of time it takes to get there. And I time is the amount of time it takes, or I should say, the amount of time we stay there. So when do we utilize rise time? Well, the important thing to know is that rise time is only relative to pressure. So in the LTV 1200, if you're utilizing BiPAP or CPAP and you have an apnea backup set, rise time is going to be in play in that setting. If you're in pressure control ventilation, rise time is going to be in play. If you're in volume, rise time is not being utilized. You cannot use rise time. So rise time is only indicative of a pressure delivery. If you look at the Revell ventilator, again, if you have a pressure control ventilation, if you have BiPAP or CPAP, it's used. It's used in BiPAP or CPAP in the backup, apnea backup. When you're in PRVC, it's also in use. So pressure regulated volume control is also in use. So how can we utilize rise time for this patient? And what does rise time do? What does that mean? Well, if you ever go into your vent, and I encourage you, if this is the first time you've heard of rise time, go in, again, hold that select button down where your window is, where it kind of flashes through your PIP and your exhale tidal volume, all those things. If you just hold that down, it's probably about 4 or 5 seconds. You'll see that vent op, alarm op kind of pop up. Each ventilator that I talk about is a little different as far as how you scroll through. But kind of play with it, scroll through, and what you're looking for, again, is going to be vent config. And you're going to scroll to, you see rise time. And so you're going to hit select, and you'll see that it will default to a rise time profile of 4. And so there's 9 different profiles. So what do those mean? Essentially, again, rise time is the amount of time it takes to get there. So a rise time profile of 4 is kind of right in that middle. So let's start at a rise time of 1 and just kind of articulate what that means. A rise time of 1 is going to take 1/10 of a second for that breath to get there. Again, think about the time it takes to get there. So it's going to deliver a breath over 1/10 of a second. So that's really, really fast. And so in some patients, that's what's needed. And this patient we're talking about in this case is exactly that. If you have a patient where your tidal volumes are limited, right? We don't want to go so high on our tidal volume because we're in a lung protective state. This patient is an injury approach. We've already raised the tidal volume. We're translating what we just did with the BVM. We're utilizing a higher tidal volume. We're lengthening our I time down or out, right? Making that I time longer. Again, just like we did with the BVM. Our FiO2 is 100%. Our PEEP is at 10, we'll say. You can utilize rise time for this patient and think about delivering this breath more rapidly. And that is going to be better sometimes for patients that have a high corresponding peak inspiratory pressure and we're limited on our tidal volume like that. It's going to help overcome that issue. It's going to deliver that breath in a more rapid fashion. Again, that's not going to be for all patients, and you may have to play with this because really, for me, intuitively, you would think that delivering that breath over a longer period would be better for recruitment. And for a lot of patients, again, that is true. You're going to have to play with it. I've utilized this on patients just like this, and for some reason, when you have that corresponding high peak inspiratory pressure, delivering that breath over that 1/10 of a second is more optimal. All right, so what does the different rise time profiles mean? Well, there's 9 different profiles, and a rise time profile of 1, again, delivers a breath over a 1/10 of a second, so 0.1. Rise time profile 2 is 0.2, and so on. So every single rise time profile increases by a 1/10 of a second, right? Until you get to a rise time profile of 9, and that profile of 9 is delivering the breath over almost 1 second, so 0.9. And so you can see that you can play with this. I encourage you to put your ventilator on a test lung. If you have the ability to look at this with actual pig lungs, you'll be able to see the difference in how that breath is delivered. It's really, really important and cool to see how a pig lung responds. And I may actually do a video to kind of illustrate the different profiles on the LTV 1200. That's what I have to use, and kind of put that on YouTube, and I'll attach it to this. I probably won't get to this morning, but I'll try to do this in the next couple of weeks, and I'll put an email out to everybody, or I'll announce it on another podcast so you can kind of see. But I encourage you to try this, to look at this. And I think the important take-home point is, don't just give up on your ventilator. Utilize these different things. Always be a student. Always be practicing. Always be pulling this out every single shift. You're never going to dominate the ventilator until you play with it every single shift. It's constantly a learning thing. Even as comfortable and confident as I am on the ventilator, I just had a Revel for a couple weeks, and there were certain things on that Revel that I had forgot. And it's really important to always pull it out and play with it. Just turn the dials, man. If you're sitting in the recliner watching TV, pull that thing out and play with it. Turn it on. Mess with the buttons. Be more confident in your manipulations. And I think you'll have a better kind of understanding and better success with your patients if you kind of understand what you're doing. So those are a few little kind of core tips that I would suggest in a patient like that. And I think the big take-home point is, translate what you just did with the BVM to your ventilator, and I think you'll be successful. So hopefully this was a kind of good overview of some advanced concepts of looking at hypoxic patients. Remember, your BVM is a BLS tool, and if you can get that to work, right, you're doing it by accident. You're doing it just based on what you've been trained. Translate that back to your ventilator, and I think you'll be successful. If you have any questions on this, if you have any comments, any tips, please email me, eric.bauer@FlightBridgeED.com. I want to thank everybody again, and until next time, I'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.